lecture will be approach to proteinuria in pregnancy and preeclampsia. My patient is 6 years old, female, P2C1, POA at 12 weeks, presented with generalized edema and from the urine referred to the nephrology clinic by obstetrician. Her serum creatinine was 72, USCR was quite significant, 1464. Her complement levels were normal, dsDNA was negative, and the blood pressure was 130/70. We did a renal biopsy. It shows 21 glomes, 9 sclerosed. All 10 glomes shows increased mesangial matrix and tubular atrophy. So the diagnosis came as IgA nephropathy. So we treat her with higher dose of aspirin with enoxaparin prophylaxis, and we did the regular renal function monitoring and fetal well-being assessment and started steroids 1 milligram per kg per day as the USCR was quite high, and her USCR was gradually reduced to 840, and we were able to deliver her at 37 weeks of POA due to with the cesarean section. We did the cesarean section not due to any other reasons because her first pregnancy was cesarean. So this is the chart about how do we follow up the glomerular disease patients in pregnancy. If she is in complete remission, so every 4 to 6 weeks follow-up is enough. But if the CKD is stage 4 to 5 with significant proteinuria, she needs she needs quite vigorous monitoring. So I will not touch the physiological changes. I think it was already mentioned that during pregnancy there is mild pelvic calcial dilatation with quite hydronephrosis, and there is altered tubule function causing increased hematuria, proteinuria, increased proteinuria, glucose and amino acids, and there is vasodilatation with increased EGFR, and due to reduced thermostatic set point at the ADH, there is fluid retention. So this is the normal kidney function during pregnancy. Usually during pregnancy, the serum creatinine drops 1/10 from the below the normal range. So during pregnancy, during between 10 to 32 weeks of POA, there is reduction in serum creatinine levels and then gradually peak up to 44 weeks of POA. So this is how this chart mentioned. There is a significant 1/10 drop during pregnancy, during POA, even between 10 to 33 weeks. And usually the mean serum creatinine value during pregnancy is 60 to 78. If a person presented with creatinine of 82, 84, that is quite abnormal. So our second patient was 32-year-old female who was previously healthy, not underwent renal screening previously. She presented to us at the POA 28 weeks with quite high blood pressure with serum creatinine of 153 with EGFR of 37. So she was diagnosed with CKD with ultrasound showed polycystic kidney disease, and USCR was gradually worsened. And we started with, as previously, higher dose of aspirin, enoxaparin, antihypertensives, and induction of labor done at 36 weeks of POA due to rapidly develop of effusion and ascites. Following delivery, her renal function stable via vigorously monitoring. So this is how we categorize the CKD. So as pre-pregnancy, if the GFR is lower, there is high risk of preterm delivery and severe maternal morbidity. If the EGFR is lower with significant proteinuria, this showed that there is severe maternal morbidity as well as increased preterm delivery. And if there is lack of fall in serum creatinine during pregnancy, because we all expect fall in serum creatinine 1/10 from the normal value. If there is lack of fall in serum creatinine and if there is hypertension, they are more prone to deliver before 34 weeks of POA. So we need to identify who are at risk to deliver at preterm. So let's move to preeclampsia. I think everybody knows what is preeclampsia. It's incomplete cytotrophoblastic invasion of uterine spiral arteries, which leads to ischemia of the placenta and release of inflammatory factors. So mainly we diagnose it at 24 weeks of POA with the blood pressure of more than 140/90 with presence of proteinuria or absence of proteinuria with other maternal end organ dysfunction. So mainly if the kidney involved, it's mainly glomerulus. So it is the most commonest glomerular pathology during pregnancy. It's preeclampsia. Preeclampsia affects the glomes, causing endothelial injury, glomerular endotheliosis, proteinuria, and renal failure. Once when we detect UFR hematuria, sometimes obstetricians might be worried about any other pathologies, glomerular pathology, but most likely it can be preeclampsia, which is one of the commonest cause, which is present at 20 weeks of POA. And there is other organ involvement like brain. This causes cerebral ischemia and seizures, visual disturbances, and the lungs, pulmonary edema, and liver, I think all you know, HELP syndrome, severe liver dysfunction, and placental dysfunction, and fetal distress. So how do we diagnose? If there is blood pressure more than 140/90 with urine dipstick 2+ or protein, urine protein creatinine ratio which is more than 30 milligrams per millimoles, or either urine albumin creatinine ratio more than 8 milligrams per millimoles. That means more than 300 milligrams per 24 hours. That is urine protein. The proteinuria is not mandatory for diagnosis. So presence of liver dysfunction, evidence of AKI, neurological features, thrombocytopenia, as well as uterine placental dysfunction. When a patient presented with worsening proteinuria or new onset proteinuria after 20 weeks of POA, to confirm a diagnosis, we can do other investigations, including uterine Doppler, if it's available, maternal serum placental growth factor, and then other evidence of preeclampsia. So how to measure the blood pressure? Blood pressure should be measured in the standardized technique with the correct cuff side, which is mandatory. You measure the both arms, and if severe hypertension, you repeat it within 15 minutes and repeat it in 4 hours. So these are the risk factors for preeclampsia: chronic hypertension, chronic kidney disease, pre-existing diabetes, autoimmune diseases, first pregnancy, and family history like that. If there's a patient with preeclampsia, risk factors for preeclampsia, how do we screen for preeclampsia? So you can perform uterine Doppler, which increase pulsatile index. That means increase uterine flow resistance. That is predicts the preeclampsia in future, as well as can do the placental growth factor. As my colleague mentioned earlier, placental growth factor is reduced when there is preeclampsia, right? So in the absence of proteinuria, we diagnose with high blood pressure, systolic blood pressure more than 160, and diastolic blood pressure more than 110, thrombocytopenia, and renal insufficiency. In the CKD population with pregnancy, the placental growth factor is higher than the normal cutoff value. It's around 150, which is 100 in normal population. And if it's lower, we can predict the diagnosis of preeclampsia. As well as if there is increased uterine resistance in the uterine Doppler, we can recommend at the early pregnancy low dose of aspirin. So there is complicated pregnancies, accelerated loss of EGFR. So when we compare complicated versus uncomplicated pregnancy, there is accelerated loss of EGFR in complicated pregnancies compared to the uncomplicated pregnancies. So this is the proposed approach to suspected glomerulonephritis in pregnancy if the patient presented with before 32 weeks of POA. So you can do serological investigations like ANCA, dsDNA, and C4C3 levels. And if there is a severe life-threatening maternal disease, you will consider termination. If there is life-threatening disease for maternal, like high-risk bleeding, high-risk thrombosis, we will consider termination. And if not, if it's possible, we will go ahead with the renal biopsy. Refer to a nephrologist to do the renal biopsy. And the other thing, if the patient denied renal biopsy, or if there is a high risk for renal biopsy, we can start empirical treatment. So empirical, we can give steroids, azathioprine, or calcineurin inhibitors. If we suspect lupus nephritis and ANCA, we can consider rituximab. It was risk versus benefit ratio because rituximab can cause fetal B cell depletion. And if they present with more than 32 weeks of POA, to make a possible diagnosis, We can't do histology biopsies after 32 weeks of POA, but we can do other serological manifestations, serological tests like C4C3, ANCA and dsDNA antibodies. And if patient is having severe life-threatening condition, we need urgent delivery. I mean like worsening proteinuria with profound ascites and effusion, we need delivery, and in the fetal distress. Or otherwise, we can give a trial of empirical treatment if we suspect other glomerular pathology, like we can give trial of steroids and consider lupus, we can give calcineurin inhibitors, or considering ANCA, we can treat with rituximab. It depends on individualized, so we can consider that. And postpartum, we can perform a renal biopsy with histological diagnosis. So always assume new onset or acutely worsening proteinuria after 24 weeks of POA, it is preeclampsia other than any other causes. And the biomarkers will be helpful, and mainly placental growth factor. So this is how post-preeclampsia follow-up patients, there is a risk of chronic kidney disease development as well as chronic kidney disease development following preeclampsia. So this is how we differentiate other glomerular pathologies from preeclampsia. So lupus nephritis can present at any trimesters, can be accompanied by rash, arthralgia, fever, and worsening proteinuria and urine active sediments. And hypocomplementemia is very, very important, because normal pregnancy, the complement level is normal, but in lupus nephritis, it's low. And the treatment is, as we all know, immunosuppression. Steroids, azathioprine or calcineurin inhibitors, rituximab plus or minus. Antiphospholipid syndrome, they can present in all trimesters, and they can present with history of recurrent pregnancy losses, other thrombotic events including livedo reticularis, and they present with, can present with proteinuria but not with urine active sediments. And the blood film shows thrombocytopenia and prolonged APTT. And preeclampsia, they present mainly at more than after 20 weeks of POA gestation, and they present with hypertension and, as I mentioned, other organ manifestations, and the biomarker elevated SFL2 to PGF2 ratio, and they may have thrombocytopenia, liver dysfunction, and the treatment, there are indications of delivery, I will tell you in preeclampsia. And HELP syndrome, it's delivery, and they present with more than 20 weeks of gestation, hypertension and headache, and they present with anemia, low platelets, elevated liver enzymes. And the acute fatty liver in pregnancy, delivery is the treatment modality, and pregnancy associated atypical H2S, mostly present, almost all at postpartum, not before that, and we do not have the treatment here, it's only eculizumab. And TTP, it's plasma exchange, they usually present with neurological manifestations and hematuria, proteinuria present. And there is reduced adaptation. So what are the clinical signs and symptoms of preeclampsia? Severe headache, visual disturbance, papilledema, oliguria less than 400 ml per day, and abnormal liver functions. And the eclampsia means development of convulsion or unexplained coma during pregnancy. So how do we prevent? Aspirin, as well as daily intake of calcium and exercise during pregnancy. And the treatment of hypertension, this is the newest guideline in BMJ that shows that labetalol is the first line of drug, and then nifedipine second line, and methyl dopa is the third line. And we need, if the hypertension in pathway, we need, if the patient's blood pressure is 140 over 90, she doesn't need admission but needs proper monitoring once or twice per week. And we can, if we can do a placental growth factor blood testing to predict preeclampsia, or either uterine Doppler to predict the preeclampsia. And if it's higher, we have to do the daily monitoring. And if it's preeclampsia, as I mentioned earlier, we need frequent monitoring and monitor for other organ dysfunction. So this is how you manage hypertension. We treat if the oral hypertensive use can be given. If it's very high, we can consider IV as well. And this is how it start with labetalol, 100 milligram 3 times per day, gradually increase to 200 to 300. and nifedipine is 10 milligram, gradually increased 20, 30, and methyl dopa, it's like that. So labetalol is the first line drug. So management of preeclampsia, we usually give intake output with adequate intake of 80 cc per we usually give, with look for complications, and what are the indications for delivery. If there is any possibility of deterioration of the fetus, like B mode, BPP score is less than 4, that's indicate of the delivery, and as well as you can do the fetal Doppler, fetal heart rate, and other indications like abnormal rise in AKI, hepatic dysfunction, and maternal compromise, pulmonary edema, seizures, developing of eclampsia, severe hypertension not controlled with 3 drugs. And for the prevention, you can have to give IV max sulfate. It's 4 gram followed by 1 gram infusion per hour infusion, and these are the imminent signs of eclampsia. I think I will not touch the AKI because it was already mentioned. So these are the medications considered safe in pregnancy. Thank you.